going?
Hi, I'm Dave DeFrancisco, a first-year rheumatology fellow at the University of Colorado, coming to you from RWCS 2023. Excited to share my case with you about a consult in the burn ICU where we were asked to try to help figure out the difference between toxic epidermal necrolysis and an acute cutaneous lupus eruption. So this was a really interesting case, really highlighting the diagnostic dilemmas that we often face as rheumatologists. It was a 30-year-old female who had had 2 weeks of a blistering erythematous eruption and a malar distribution on her face, as well as her chest and back and shoulders. She was transferred in from an outside hospital to the burn unit. And she had had some intermittent malar rash over the previous few months, as well as some oral sores, but her review systems were otherwise negative. And an important piece about her history is she had been diagnosed with lupus roughly 5 years prior, just with a low titer ANA, as well as possible myocarditis and a malar rash in a different state. And 6 months prior to her presentation to us, she had had some skin biopsies done in another state as well, and they came back not suggestive of lupus. So her hydroxychloroquine, which she had been on for the previous 5 years, was stopped 6 months prior to this presentation. So whenever we saw her, she was febrile. She had very impressive malar distribution of an erythematous rash with dark eschar. She had bullous eruptions on her arm, shoulder, and back, but otherwise her exam was pretty unremarkable. So I think it's important, to just briefly discuss the differential when you see a bullous eruption in a patient like this. So the main reason we were asked to see her, the possible lupus manifestations, the first one would be a bullous lupus erythematosus, very rare acute cutaneous manifestation, which is characterized by photodistribution of small tense bulli, and histologically you'll see subepidermal bulli with neutrophil infiltration of the upper dermis. And importantly, the direct immunofluorescence should always be positive and demonstrate immune complexes. The second one is TEN-like acute cutaneous lupus. Again, very rare manifestation. Again, you'll see a photodistribution of rash, and then also you'll see larger bulli. And on biopsy, you'll see subepidermal necrosis, which you see in TEN, and you'll also see features of underlying acute cutaneous lupus like interface dermatitis, dermal mucin, and just perivascular inflammation. And then finally, TEN. So classically, we associate that with medications, anti-epileptic drugs, or even infections, and involving greater than 30% of the body surface area. And on histology there, you'll see subepidermal bulli, but you should not see a lot of lymphocytic infiltration. So in terms of the data for this young lady, she was pancytopenic, she had AKI, transaminitis, elevated CK, she had some hematuria, proteinuria, but interestingly, her ANA was negative. Her C3 was mildly low, and her anticardiolipin IgM was mildly elevated. So she was started on some IV fluids and systemic steroids, 1 milligram per kilogram, as well as hydroxychloroquine. With that treatment, her AKI and her proteinuria hematuria resolved, so they were likely prerenal in nature and not due to underlying connective tissue disease. On her biopsy, she did have a subepidermal bulli, and she did have some perivascular inflammation, dermal mucin, and interface dermatitis there. So features on there were more suggestive of something like a TEN, like acute cutaneous lupus, rather than toxic epidermal necrolysis. But with a negative ANA, it does kind of raise that question of whether this patient truly had lupus or not. Ultimately, we did feel like this was an acute cutaneous lupus manifestation due to her prior history with the positive ANA and the fact that her rash really came on after the Plaquenil was stopped, as well as some of the other systemic manifestations she had, like the pancytopenia, hypocomplementemia, and the positive anticardiolipin IgM. Thanks.